Thank you for that introduction and for the invitation to speak. You can see my disclosures there. I want to speak today about ghrelin and cancer cachexia and age-related sarcopenia. I know that probably some of you are very familiar with ghrelin, but I'll give just a brief introduction. So you can see in this cartoon, ghrelin is a hormone derived primarily from the stomach that was discovered in 1999 and as the endogenous ligand for the growth hormone secretagogue receptor 1A. This receptor had been cloned in 1997, but its existence was actually known since the early 90s because several compounds known as growth hormone secretagogues have been developed and were actually in clinical trials since the early 80s. And so we actually have clinical data going back 20, 30 years for some of these compounds, in spite of the fact that the pathway was only more recently discovered and is still being characterized. In addition to inducing the secretion of growth hormone, ghrelin has been found to increase food intake and more recently to have several other effects, including decreasing inflammation, increasing protein balance in muscle, increasing adipogenesis in adipose tissue, among other effects. Now, these effects in skeletal muscle and adipose tissue are present despite the fact that this receptor, the GHSR1A, is not present in skeletal muscle or in adipose tissue. And these effects have been seen in vitro models of isolated myocytes and adipocytes, suggesting that not all of ghrelin's effects are mediated directly through this receptor. I know you're all familiar with what cachexia is, and so I'll just make the case that these widespread effects make ghrelin a very suitable candidate to treat cancer cachexia. And in fact, there have been several clinical trials have run some of the early phase studies, and here's data from more late phase studies that have tested the effect of growth hormone secretagogues in the setting of cachexia. As you can see here from the Romana trials, activation of the GHSR1A with this ghrelin receptor agonists cause an increase in appetite, lean body mass, fat mass, and body weight. But unfortunately, they fail to induce improvements in grip strength or muscle function measured by grip strength. And so I hypothesize or propose that it's part of the reason why we're not able to design clinical trials that are effective is the fact that we don't fully understand how ghrelin works. And so we don't have a full understanding of the pathways mediating the effects of ghrelin. So we decided to pose sort of more basic questions, and some of them are, does ghrelin signaling play a role in cancer cachexia? Are muscle mass and strength differentially regulated by ghrelin? And what is the role of the GHSR1A in mediating ghrelin's effect in this setting? So for this, we established the LLC cancer cachexia model in GHSR wild type and knockout mice, given that both models, the LLC and these knockout models, are using the C57 background. Tumor implantation induced, as you can see on the upper left part, a greater degree of weight loss in knockout mice than in wild type, and it induced a decrease in grip strength in both. Muscle mass, fiber cross-sectional area were also decreased by tumor implantation. Ghrelin prevented the decrease in muscle mass and cross-sectional area in both wild type and knockout mice, but it only prevented the decrease in grip strength in wild type mice, suggesting that GHSR is required for ghrelin to restore muscle strength, but not necessarily muscle mass. LLC implantation induced a greater increase in atrogens in knockout than in wild type mice, as you can see here on the top left. And ghrelin prevented this increase in both animals, so suggesting that GHSR is not necessary for these specific effects. Autophagy markers were also increased more in knockout mice. However, when autophagy flux was tested using colchicine, we detected an increase in LC32 in wild-type mice that was partially prevented by ghrelin, suggesting that this receptor plays a role in phagosome degradation that is responsive to ghrelin. When we measure markers of mitophagy, there were increases, these were increased by LSC in both genotypes, and this was ameliorated by ghrelin only in wild-type mice. Also, there was an inverse correlation between these markers and grip strength, as you can see here on the bottom right. We also looked at mitochondrial oxidative capacity and found that knockout mice had lower mitochondrial respiration before implantation. In wild-type mice, LSC-induced decreased respiration that was prevented by ghrelin. LSC implantation induced increases in energy expenditure and decreased locomotor activity in RQ. And these effects were greater in knockout mice than in wild types and were not responsive to ghrelin treatment. So to summarize what I just shared with you, we found that GHSR1A deletion exacerbates LSC-induced cachexia, causing greater weight loss, resting energy expenditure, and activation of the UPS and autophagy systems. Ghrelin ameliorated LSC-induced muscle mass loss and UPS activation independently of GHSR1A. And ghrelin prevented LSC-induced decrease in grip strength, mitophagy, and mitochondrial dysfunction via GHSR1A. Lastly, GHSR1A plays a role in regulating skeletal muscle fiber cross-sectional area, autophagy, and mitochondrial respiration. So now, based on what we know about ghrelin and GHSR, we wanted to also look into the role of ghrelin in the setting of sarcopenia. So sarcopenia, unlike cachexia, tends to be a more chronic disease. So we know that cachexia tends to happen relatively acute or subacutely in patients, for instance, usually ensues between months, versus sarcopenia that usually takes years to develop. There's some features that are common to both, such as the loss of muscle mass and function. But unlike cachexia, where there's profound anorexia usually and fat loss, sarcopenia usually is associated with fat gain, and anorexia is not as important. So the question that we're trying to answer here is, does ghrelin signaling play a role in sarcopenia of aging? So ghrelin knockout animals more prone to age-related sarcopenia, and how does ghrelin affect body composition, muscle function, and energy balance in old animals? So for this, we now took animals that lack the ghrelin gene, so not the receptor knockout, but the ligand knockout, and we aged them to 20 months of age approximately. Aging led to an increase in body weight and fat mass, and to a decrease in endurance and strength, mimicking the pattern that we see in all people. Ghrelin deletion partially prevented these changes in body composition as expected, but also prevented the changes in muscle function, which was somewhat surprising. Also, ghrelin led to led to a decrease in food intake, energy expenditure, and locomotor activity, again, mimicking what we see in humans. And ghrelin deletion was associated with lower food intake with young, although not with aging, and prevented this aging-associated decreases in energy expenditure without altering locomotor activity. To understand some of the mechanisms that are underlying these observations, we performed measures of muscle cross-sectional area and fiber typing. And what we found was that even though there were no differences in young animals, ghrelin deletion led to an increase in type 2A muscle fibers with aging. We also probed some molecular markers, and what we detected an increase in androgens, MORPH1, and androgen. Some of the other markers like AKT, FOXO, or IGF-1 mRNA in muscle were not different. The only differences we saw between wild type and knockout mice were that IGF-1 levels in circulation were lower in knockouts than wild type. This is expected given ghrelin's known effects on the growth hormone and IGF-1 axis. We also looked at AMPK and some of the downstream mediators, fatty acid synthase, pyruvate dehydrogenase kinase 4 or PDK4, given that AMPK is a non-metabolic regulator that promotes mitochondrial biogenesis and is associated with greater endurance, which is part of the phenotype that we detected. The decrease in p-AMPK, fatty acid synthase, and PDK4 levels seen with aging, which have been previously reported as well, were prevented by Ghrelin deletion, suggesting that this may actually play a role in the effects that we saw with Ghrelin deletion.
Grazie.
We also wanted to test the therapeutic effects of Ghrelin administration chronically in old animals. And so we treated for a month these old animals with and without the Ghrelin gene with subcutaneous Ghrelin administration using the same regimen that we had used in the Cachexia model. As you can see there, Ghrelin administration increased food intake, body weight, lean mass, fat mass, and grip strength in these animals without affecting endurance or other parameters, including AMPK. We have published these results, and I'm not including them here for the sake of time. So in conclusion, in this model of aging, we show that lifelong Ghrelin deletion prevents obesity associated with aging by modulating food intake and energy expenditure. And it also attenuated the decrease in muscle p-AMPK and increased the number of type 2A fatigue-resistant oxidative muscle fibers, preventing the decline in muscle strength and endurance seen with aging. Treatment of all mice with pharmacologic doses of Ghrelin, however, for 1 month, increased food intake, body weight, and muscle strength. So taken together, a working hypothesis is that we're looking at 2 different conditions here that, although in the clinic they tend to overlap, and these 2 models are somewhat distinct. So in case of cachexia, we see this is an acute model where we have profound anorexia, and there's actually an increase in energy expenditure. So if we look at the tissue levels, we see an atrophy of both fat and muscle that leads to functional impairment and decreased spontaneous locomotor activity. Sarcopenia of aging, on the other hand, anorexia is not as profound, and we see a decrease in energy expenditure. And so these chronic effects lead to muscle atrophy and functional impairment, but fat hypertrophy. So these 2 lead to decreased locomotor activity. Of course, locomotor activity per se, in both cases, can have a bidirectional relationship with muscle atrophy. And so if you have decreased locomotor activity, you will also have muscle atrophy and weakness subsequently. So Ghrelin, we know that targets actually a lot of these pathways that can modulate some of these targets. And so we know that it prevents anorexia. And so this will clearly have a more profound effect in the setting of cachexia than in the setting of sarcopenia of aging. And that will target muscle mass and muscle function indirectly, for instance, via modulating growth hormone IGF-1 axis, but also by increasing the availability of nutrients, which is more important in cachexia probably than in sarcopenia of aging. We also know that it affects fat mass, and so it will actually probably exacerbate fat hypertrophy and prevent fat atrophy, depending on the setting. Some of these effects are not necessarily mediated through the GHSR and appear to be GHSR independent. So this understanding these pathways and how a GHSR plays a role in mediating Ghrelin's effect will be important, for instance, as we develop this target for clinical trials. So perhaps using a GHSR-specific agonist that sort of deprives Ghrelin of its effects that are independent of the receptor is not the best way to target these conditions. So it was interesting that we saw—
4 minutes left.
Thank you. We saw improvements in some of these parameters with ghrelin treatment in both models, sarcopenia of aging and cancer cachexia. And so it seems to me that acutely ghrelin will have a beneficial effect. The chronic activation of this pathway, the effects will depend also on the type of model that we're using. So with this, I want to acknowledge the people that performed the work in my lab, particularly Jian, Bobby, Jiahuan, and Haiming, that developed a lot of the work that I shared with you today. And also, of course, the funding agencies that pay for this work, Department of EA, Department of Defense, and the NIH. Thank you very much.
Well, thank you, Dr. Garcia, for an excellent talk. I really appreciate that. We've got about 3 minutes left here for questions, and I'm just going to briefly start with probably a very simple question, and I hope this is not something I missed in the talk. But if I remember right, you opened with the fact that the ghrelin receptors are not found in muscle, correct?
That is correct.
And I'm assuming that when you've looked in normal muscle. Has anyone or you looked in muscle that is in some type of pathology, some type of pathologic situation, muscle that is atrophying in response to cancer cachexia or starvation?
Yes, we have, and I believe other groups have also looked, at least in aging. We have tried to detect and failed to find this receptor expressed in both our models, old animals as well as cachectic animals.
Are there any other questions for Dr. Garcia? We've got about 2 minutes left. I'm going to turn it back over to Dr. Heppel.
Yeah.
Hi there. All right. Thank you. That was a really nice talk. I'm curious to know, I may have missed this little detail. How old were your mice in the Ghrelin knockout experiments at the termination?
Yes, so that is obviously a very important point. So the data of the mice that I share with you are 20 months old mice. Some of the experiments that we're performing today in the lab we're taking this all the way out to 30 months. And so we see how there's a disconnect then, or different trajectories when you look at fat than when you look at lean mass. So muscle mass and muscle function continue to decline with aging. Muscle mass, so this obesity, so the sarcopenic obesity that we see here, goes away with aging. So as animals get into the late phases of aging, they also suffer fat atrophy. So we're now studying actually the current experiments. We're taking one time point more at 30 months. And so we still haven't fully characterized what are the molecular changes of this phenotype later in age.
Are you considering looking at the neuromuscular junction?
Yes, so that's something that we haven't done yet, but this is something that is known to be affected in aging. And so it's one of the things that we're gonna look into.
Terrific, thank you.
And maybe we have time for a question from Erin. I see the hand raised.
Hey, Jose, thanks for a great talk. Did you figure out if your feeding effect with ghrelin in your LLC mice was receptor dependent? You may have showed it and I missed it. Like, do you still get increased feeding in the knockout mice?
No, you didn't miss it. I didn't show it, although it is, we did publish it. I didn't want to have too much data on it. It is growth hormone receptor, growth hormone secretagogue receptor dependent.
Thanks. The
same is true for the growth hormone effects. So growth hormone and appetite effects depend on GHSR1A.
Right, I guess Carlo and Paulo still have the hand like that from the previous talks. So I don't know, just maybe a question to close the loop with the previous talk. I was struck by the fact that you have shown that ghrelin increases muscle strength in the absence of the recovery of muscle mass, and basically it improves the mitophagy and the respiration, that is endurance. I was just wondering whether it is known if ghrelin could have an effect on the level of ROS, for instance, ROS production.
Yes, so that is something that we haven't looked into yet. So we've looked at mitophagy and we looked at OXPHOS, but we haven't measured reactive oxygen species yet. So that's an excellent suggestion. We're planning on doing it.
Oh, thank you very much.